Dear experts and colleagues, I'm Manu from Sichuan Cancer Hospital. My topic is the value of CUS in cancer pain. There are 4 parts in my presentation. First of all, I want to say something about cancer pain. Recent advances in medical knowledge, including the use of new drug therapies, have prolonged the life expectancy for many cancer patients. As a common comorbidity of malignancies, cancer pain has an incidence up to 61.6%, which was even higher in advanced cancer patients. Among all the factors leading to cancer pain, tumor accounted for 78.2%, which includes compression of nerves and organs, necrosis, ulceration, and inflammation. In 1986, the World Health Organization put forward the 3-step analgesic method for cancer pain, but systemic analgesics are limited by inadequate pain alleviation or intolerable opioid-related adverse effects. In 1996, the WHO added interventional therapy in cancer pain guidelines, namely the concept of multimodal analgesia, the 4th-step therapy for cancer pain. This is the 4-step analgesic ladder. Step 4 includes nerve block, epidurals, PCA pump, neurolytic block therapy, and spinal stimulators. So, minimally invasive intervention is one of the treatment methods for cancer pain in multi-mode and multidisciplinary intersection. In our practice, CUS is mainly used in 3 aspects in cancer pain: ultrasound-guided nerve block, ultrasound-guided neurolysis, and ultrasound-guided tumor ablation. Nerve block, also known as regional nerve block technique, can realize temporal or long-term pain function loss of local area by drug or physical means. Indications for nerve block are autonomic nerve dysfunction diseases such as vegetative nerve dysfunction, essential hypertension, peripheral facial paralysis, Meniere's disease, glossopenia, and etc. In this slide, we show a 40-year-old male with oral ulcer after radiotherapy for carcinoma of tongue, whose complaint was severe pain of right hidden neck. So sternate plexus block was performed on him. The VS score was 10 before the treatment, 3 right after the SPB, and 0 1 month after the SPB. During the procedure, CUS was used to show the needle tip and evaluate the drug diffusion. Seniac plexus neurolysis has been reported to be effective in relieving abdominal pain originating from intra-abdominal visceral malignancies of the pancreas, liver, and gallbladder. Indications for CPNR patients with advanced upper abdominal cancer, pancreatic, liver, gastric, colon cancer, and lymphosarcoma, etc. Pain can be alleviated by analgesics. This case shows a 50-year-old male with pancreatic cancer who complained about severe abdominal pain. We performed CUS-guided seniac plexus neurolysis on him. The VAS score was reduced from 9 to 1 after the CPN. In the procedure, the CUS was used to show the puncture path and observe drug dispersion. In our published study on European radiology, we found that CUS-guided CPN is a safe and effective method to alleviate refractory upper abdominal pain in patients with upper abdominal cancers. CUS image allows the visualization of puncture path and observation of drug dispersion. The pain relief is relevant to the dispersion of neurolytic agent around the aorta. Ultrasound-guided tumor ablation includes radiofrequency ablation, high-intensity focused ultrasound, laser ablation, and microwave ablation. And the microwave ablation can reduce the pain caused by tumor compression, improve the survival rate and quality of life. Indications for ultrasound-guided microwave ablation are including the following items. Intractable cancer pain. The patient couldn't tolerate surgery or refused surgery subjectively after evaluation. The tumor can be treated by surgery, radiotherapy, or chemotherapy resistance. Organ compression or pain caused by enlarged tumor. The contraindications are as follows. Patients with severe infection, patients with uncorrectable coagulopathy and thrombocytopenia, patients with dysfunction of vital organs, and patients with tumor surrounding and invading blood vessels and nerves. This is a 50-year-old female with breast cancer metastasis involving sternum, ribs, and pericardium. Her complaint was pain of ribs. The VAS score before treatment was 9. CUS before ablation showed hyperenhancement in artery phase with rapidly rushed out. CUS after ablation showed low enhancement both in artery and venous phase. VAS score after ablation and intercostal nerve neurolysis was 3. The pain control effect was obvious. In conclusion, interventional cancer pain treatment reduces the adverse reaction of opioids and improves the patient's life quality. Ultrasound-guided treatment of cancer pain is visual, minimally invasive, and ineffective of appearance. CUS is helpful in visualization of puncture path, judgment of the extent of drug diffusion, and evaluation of tumor ablation degree.
Thank you.
That's all for my presentation. Thank you so much for listening.